Hi, my name is Toss. I'm a clinical associate professor, a director of the National Pancreas Foundation Pancreatic Cancer Program at Geisinger, and a co-director of the Pancreas Program at Geisinger. Today, I would like to thank the National Pancreas Foundation for giving me the opportunity to share information about pancreatic cancer in African American population. I would like to start with the background of pancreatic cancer. It has been projected that by year 2030, pancreatic cancer will become the second leading cause of cancer-related death because the overall 5-year survival of all stages is less than 10%. The only curative treatment is surgical resection combined with neoadjuvant or adjuvant therapy, such as chemotherapy and/or radiation. However, the majority of the patient presents at late stage, and it is too advanced for curative treatment. African American population has the highest incidence of pancreatic cancer, up to 15 to 17 per 100,000 population, as compared to non-Hispanic whites, with the incidence of 12 to 15 per 100,000 population. They also have the worst pancreatic cancer prognosis of all U.S. populations, with more advanced stage and more non-resectable disease at presentation, as well as less surgical treatment. In another national cohort, even though African American patients appeared to present with comparable rates of resectability, they receive care that might deviate from guidelines. Insurance status might be one of the factors associated with inferior profiles of resectability and treatments. Multiple studies demonstrated that socioeconomic factors could be associated with disparities in the utilization of surgical resection. This is a study based on national cohort of more than 17,000 patients between year 2004 and 2011. Of these, approximately 45% of patients underwent surgical resection. The study shows that white patients, as compared to African Americans, non-Hispanic ethnicity, merit status, insurance coverage, and patients in the Northeast region were associated with improved utilization of resection. They also showed that patients underwent resection had significant improved survival compared to those who did not undergo resection. In terms of regions, patients in the Pacific West, Northeast, and the Midwest had improved survival compared to those in the Southeast region. Only geographic location was independently associated with survival in patients undergoing resection. On the other hand, patients in resectable stage might refuse surgery. Factors that were associated with refusal of surgery included older age, female gender, those with several chronic medical conditions, African American patients, and those who are on Medicare or Medicaid insurance. They were more likely to refuse surgery if they were seen in non-academic settings. As a result, patients who were recommended surgery but refused had significantly worse survival compared to those underwent surgery. More recently, a large cohort from a single large insurance system from over 2,100 patients, for which more than half of the patients presented with stage 4 disease, showed that minorities were not disadvantaged in pancreatic cancer care. This might be promising that such disparities have improved over time. However, we need to verify these findings in larger cohorts from other regions of the country. Pancreatic surveillance is recommended for selected high-risk patients to detect early pancreatic cancer and its high-grade precursors. These are the genes that are associated with increased risk of pancreatic cancer based on the most recent expert consensus. Based on the consensus, it is recommended that pancreatic cancer surveillance should be performed in a research setting by multidisciplinary teams in centers with appropriate expertise. The studies of these genes included only a modest number of African American population, limiting evaluation of associations in this high-risk population. More specifically, recent studies showed that a pathogenic germline mutation in the gene named CDKN2A tumor suppressor gene could be more commonly found in African American population compared to non-Hispanic whites. The mutations in this gene are rare and associated with highly penetrant familial melanoma and pancreatic cancer in the form called familial atypical mole melanoma syndrome. It was associated with moderately increased pancreatic cancer risk among African Americans. There are several non-genetic risk factors for pancreatic cancer that are applicable to general population. These include tobacco, diabetes, obesity, and chronic pancreatitis. It is debatable if these risk factors are solely based on racial disparities, given that the results of the studies were not quite reproducible. More recent study in a multi-ethnic cohort showed that diabetes, especially recent onset diabetes, was associated with higher risk of pancreatic cancer in African Americans and Latinos. There was another study aiming at answering the risk of obesity and pancreatic cancer mortality in African Americans. Not surprisingly, pancreatic cancer mortality was associated with higher degrees of obesity. These associations were independent of gender and a history of diabetes. I consider that strategies to improve the quality of care in pancreatic cancer in African Americans should be initiated at multiple levels of care. At individual levels, patients should be aware of modifiable and non-modifiable risk factors. Those who have a strong family history of pancreatic cancer or cancer syndrome should be in consultation with your providers for possible referrals and further workup, such as genetic workup and referrals to a large academic center. Patients should be aware that even a rapid onset of weight loss and diabetes could be an early signs and symptoms of pancreatic cancer. Also, patients should be aware that they should better control other modifiable risk factors, such as smoking, alcohol intake, and obesity. On a large scale, more policies should address on racial disparities, especially for African Americans, female, and uninsured. The rate of clinical enrollment to the clinical trials, surgical referrals, and referrals to a large academic or research settings should be improved.